All right. Good evening, all. You should have gotten the official recording in progress from Zoom. That should let everyone know that we are ready to get started. Thank you to our participants who are here. Thank you to all of our panelists who are here. We know the numbers will not only continue to go up, but we know a lot of people will watch this on YouTube later. So I will start off with an introduction of myself, and then I'm going to pass it in the row of speakers that I see on my screen, and then we'll jump right into it. My name is Dr. Anani. I'm an emergency medicine physician, semi-obviously, practicing in Nashville, Tennessee. I am one of the mentors for the Tour for Diversity, past PBM to the EC for SNMA. Really happy to be here. Really happy to get you guys all into the best specialty that is EM. Dr. Landry, you are next up on my screen.
All right. Thank you, Dr. Anani. My name is Alden Landry. I, too, am an emergency medicine physician, practice in Beth Israel Deaconess Medical Center in Boston, Massachusetts. Also serve as the Assistant Dean for Diversity, Inclusion, and Community Partnership at Harvard Medical School. Got a bunch of other fancy titles that go along with all the roles that I have. But I think, as Dr. Anani alluded to, I love being an emergency medicine physician. It's the foundation for my career, my practice. It's a specialty that I love, and I think you all are making the right choice. If emergency medicine is a specialty for you, we want to welcome you to the field. I too am a mentor on the Tour for Diversity in Medicine, and I also am the co-founder of the Tour for Diversity in Medicine. And I'm glad that we partner with the SNMA and LMSA on this work that we do to promote careers in the health professions, understanding that this is a continuum. You know, our job is not only to get you into medical school, but it's to get you through medical school and being successful along your career. So I'm glad that Tour for Diversity is partnering with SNMA and LMSA for these efforts. And I'll pass it back to you, Dr. Anani.
Thank you very much. Dr. Bradby, you are next up on my screen.
Good evening, everybody. My name is Cassandra Bradby. I'm an emergency medicine physician and the residency program director at ECU Health Medical Center in East Carolina University in Greenville, North Carolina. I think this is like maybe the second or third year I've helped with Tour for Diversity. And so I'm excited to be part of this panel and talk to you guys about emergency medicine today.
All right. I see that little Gragu, aka Baby Yoda in the background. Shout out to Baby Yoda. Dr. Brown, you are next up on my screen.
Hello, everybody. My name is Cortland. I go by my first name, pronoun she, her, hers. I am the Department Vice Director for DEI at Carolinas in Charlotte, North Carolina. So working in an academic hospital. I run our healthcare disparities in EM fourth year rotation. So if you're looking for fourth year rotation, literally just email me and we will figure something out. I also have been heavily involved in SNMA, many roles, including National Vice President, National Strategic Planning Council, and then current professional board member. And I absolutely love emergency medicine. Even on the days when I hate it, I still love it.
Thank you for continuing to give back, Dr. Brown. We love you in all of those SNMA roles. Dr. Chukwuanu, you are up next.
All right. Hi, everybody. My name is Chukwuanu. I am an emergency medicine physician and an intensivist. I practice both at St. Louis University in St. Louis, Missouri, and also the ultrasound director here as well too. Had my role previously in SNMA was as a RD2, so for the legendary Region 2, regional director, and I am happy to be here today to discuss emergency medicine and what emergency medicine looks like, and knowing that emergency medicine is what public health and social justice looks like in healthcare. So I'm happy to be here with you.
All right.
Hey, Dr. Anani, do you mind if I take a point of personal privilege here and just say that one thing that I really appreciate about this group is that we are all friends and colleagues. We've known each other for different numbers of years, and I will admit that I'm the old head in this group, so I've known you all since before your times in emergency medicine, with the exception of you, Dr. Bradby. I knew you when you were a young attending, I think. Even still, we all go back. And so if you notice that our dynamics are very casual, I think part of that is how we approach emergency medicine, because it's a stressful profession, but we also recognize that sometimes you gotta, I'd say let your hair down, but I don't have any, but you got to relax and be around your folks. But then also we know each other quite well, and we've all built personal and professional relationships amongst this group. And so this is a great group to hear from, because although our perspectives may be different, I think we all know each other are coming from a genuine space and trying to support you.
Thank you very much, Dr. Landry. That is completely true. My barber says I may be headed your way pretty soon. We will see. I'm gonna hold out a little bit longer, just a little bit longer.
Hey, it's all right, man. It's all right. It's a safe space. Come on over.
All right, before we get started, I want to give everyone kind of like the rules for the evening. So this is a panel to help you guys get into emergency medicine. We got deans, we got assistant program directors, specialists, mentors, all here for you guys. So that means your questions take priority. Do we have a set of questions to fill this entire hour? Yes. Can we just kick back and talk about the last NMA conference or who's going to ACE up in Vegas? Yes, we could do that too, but we're here for you and we'll do that on our own time. So what that means, chat box, Q&A box at the bottom of the screen. Use it. Ask the questions. I'm your moderator for the evening. I'll grab all of them. I'll put them in the chat to our panelists. If you want to be anonymous, that is fine. Be anonymous. If you want to use your first, last name, and government name so we can memorize it when we see your application when it comes across our tables, you can do that too. Whatever you want to do, we're here for you guys. So we're going to jump in with our first preset question. And then this being a group of future emergency medicine residents, I anticipate there'll be questions coming up very soon. So I'll switch to yours. First question I have for our panelists is a heavy hitter because we do EM, so I'm starting out the gate. 2023, we was down bad. Numbers was looking not great. Open programs, open spots. 2024, we had a little bit of a comeback, a little bit of a resurgence. From where you guys are sitting in your seats of, I'll call it academic prestige, what do you guys think 2025 is going to be like? Are you seeing a higher number of applications or anticipating, a higher number of applications coming through? What should residents be looking out here for? And I will go the opposite way. So Dr. Chukwuanu, as you thought you were going to be last, you first up this time.
No, I think that's a great question, and I think it's something that we all anticipate. I think we were all thrilled that emergency medicine kind of rebounded strongly last year, and that many of our programs that didn't fill the previous year filled, but we still had a lot of programs that were left unfilled and a lot of positions available, which is good for the person that's applying because you definitely be considered at many more programs. But in terms of the specialty, still took a little bit of a hit, but improving. I think for this particular year, I think, from my perspective, I think applications will be on par for what they were last year. That's what I expect. I don't think we'll go back to what 2 years ago and have this large crash in emergency medicine. I think the programs and the applicants are better aligned in what emergency medicine is and what the state of the specialty is in terms of applications and interviews. And so I think we'll be kind of in line with what happened last year and maybe a little bit of an improvement. There's definitely still going to be some open spots because we have a lot of different programs, a lot of new programs. Emergency medicine has increased in the last several years in terms of residency spots available and new programs. So there's still going to be some spots available, but I think it just takes a wise application schedule from the applicant and a wise review from the programs.
Dr. Bradby, would you like to weigh in on that question as well?
I agree for the most part. I think we are going to see about the same number of applications. I think that the distribution of those applications is going to look different or maybe a little bit similar to last year. So I think there's going to be a higher percentage of applications from international medical graduates or folks who went to medical school outside of the United States, which I think historically has not been as common in emergency medicine. With the advent of the standardized letter of evaluation like a decade ago, I think that we saw a large drop off in applications from IMGs. And so I think there's probably a resurgence of IMGs to EM as a result. I think the distribution of MDs and DOs was also different last year. I think we saw more osteopathic applicants than we had historically. I think these aren't bad things. I think it's a change for EM. I think it also allows us to increase the diversity in our specialty and to respect the things that others bring to the table that historically have not come like through our programs. So
great points. I'm going to use a line that Dr. Landry uses all the time. Let's unpack that a little bit. So Cortland, I'm going to have you go first, and then I'm going to go to Dr. Landry. At your site or shop, as we like to say, how is your program going to deal with those increased numbers coming through this year? on your holistic review, is IMG now going to be a plus? Is it going to be a minus? What are you doing with these new students coming towards your program?
Yeah, it's a great question. So I honestly don't think we will do anything different than what we have been doing. We, similar to most programs, try and take a holistic view. And so looking at what unique aspects of the student's identity that they bring, have there been particular struggles? So do they have more of like a resilient background and they're going to bring that? Basically, what will they bring that will add to the community? So we think about like a culture add rather than a culture fit. We want people that come from all different backgrounds. That includes, IMGs, individuals from everywhere. So I personally don't think it will really be that different.
All right, and I'm gonna be true to my word. There's a question in the Q&A. I know Dr. Bradby's typing, but I'm also gonna still bring in other panelists to answer this. So using the last question, Dr. Landry, as well with this student's question, which is, would you advise DO students to apply to programs that historically haven't accepted DOs? So, you're at a very, very big, I will use the word prestigious program. How would you advise DOs to tackle the entrance into your program as well as those IMGs?
I think it's an interesting question because you want to go to places that are going to welcome you and invite you, and you want to feel as if you are part of the community. And so I think it is important for you to be strategic as an applicant in looking at the places that you are going to apply to find out, is this a place that will accept me as what I am? In the practice of medicine, my patients aren't looking at badges to see whether it's MD or DO that's caring for them. They want to know, can you make sure that this diagnosis is correct as you're providing this care for me? So I think from a long-term perspective, it does not matter. From a short-term perspective, it matters greatly. While there may be programs that have historically not taken osteopathic or international students, sometimes that is an old guard tradition where the faculty, the program directors have held that viewpoint. But if there's been transition recently amongst those programs, within their leadership, it may be a time for you to consider applying there. But I would only, and I think this is our global discussion here, is you want to apply to programs that you are going to feel as if you are in the best place to learn and grow. And if this place is not a place that is going to support you because of your the degree that you hold as you graduate from medical school, then maybe it's not the right program for you. So be strategic in how you approach the application process. Be thoughtful in engaging with program directors beforehand to see if it's even worth submitting that application. But also think holistically, is this a place that is going to accept me and is going to train me well? And whether that's a prestigious program with fancy titles and lots of NIH dollars that come into the residency program, or it's a county program, as we could like to call them, or a community-based program that sends great trained physicians out into rural and suburban communities to practice emergency medicine. Think about where you want to be, and will that place support you in the development of yourself as a physician in emergency medicine. I think Dr. Brown wants to answer that one too.
Yep. So I also just wanted to chime in because it's a little bit of a self-fulfilling prophecy. So if students, we'll just go with DO students, for example. So DO students don't think that they'll be welcome at a place, then they're not going to apply, then they won't see more DO students at that place, and then others won't apply. And so I would say 100% agree with everything Dr. Landry said, but also don't just look at raw numbers, because also there's oftentimes not that many residents at each program. And so given that DO students are having more of an influx into emergency medicine, which I agree is also great, you might not see, 40% DO students in each class. You might see none, honestly, but it doesn't necessarily mean that that program isn't welcoming. It might. But what you can do is you can look out to past graduates. A lot of times the residency websites will have a list of all of their past grads, and usually it'll say the degree. And then just feel free to reach out. Like, people love to talk about their experience. If they don't want to talk about it, it's not going to be anything negative. Like, that'll be a sign, if anything. And if you can't find any DO residents, reach out to DO attendings. If there are no DO residents or attendings there, that's probably a red flag.
I think that is a huge, huge, I will call it pearl right there. I'll steal from MRAP. DO attendings who may or may not be there may still know the insides of that program. So that's a great question. Also, I forgot to give my one caveat. If you hear loud background noises, these two small human beings call me father. So if some twins run up in here or make noises, apologies. We will now tackle our questions. We will go to the anonymous question first. I will split this into two parts, starting with you, Dr. Chukwuanu. How important do you feel research and publications are for applicants to emergency medicine, and how do they influence, let's say, the selection process at your shop?
I think that research and publications are always a good piece of the application, but like I said, it's a piece of your application. I don't think you need to put too much of a emphasis on research and publications if that's not something that may not be as attainable at your shop. It's always good to be involved in all aspects of emergency medicine. What I usually tell people on the application is there's many different boxes on there. Make sure you have something in each box if you're able to. Because when you don't have something in each box, it may detract from your overall application. Now, if you're able to, even if it's, getting a case report in, a QI project, a poster presentation, that kind of fulfills something in that research box and shows that you're actively engaged. And it doesn't necessarily have to be emergency medicine. It should be emergency medicine related, trauma, ICU, toxicology, something that's emergency medicine related. If you're going to do research and publications, I know in my particular program, we don't have a very, very heavy emphasis on your previous medical school research. We just really want to see that you're involved in organizations, involved as a medical student in your community, but research is a component that we look at just of your overall involvement.
I'm gonna go to Dr. Bradby for the second half of this application. All right, this applicant's now applying to your program. They have zero research on the application. What strategies or experiences would they use to stand out or show their commitment? And I'm gonna add a little tagline to this to be very specific. Where are you looking next in that application? Is it impactful experience? Is it meaningful experience? Is it hobbies? Where else are you looking on that application?
I'll be truly honest, I could care less if you did any research or not. I mean, if you're into research, cool. I'm happy to support that endeavor for you. But if you didn't want to touch a pipette with a 10-foot pole, I'm okay with that too. I concur with that opinion. And I say that as the person who did fibroid bench research in med school as my research. I did have real interest in it, for the record, but I'm just saying, you don't need that. I do want to caution you, if you're someone who is not big into research but did it to check the box, you need to go find out what happened with that research after you stopped collecting data. You need to know something about the project and what was done with it, if it's still going, if it had a poster, something. Because otherwise it definitely, when I ask you about it, sounds like you were checking the box, and that sounds like a waste of your time, honestly. Because you can't talk to me about it. The next place I'm probably going, seeing as I don't look at research as my primary thing that I care about anyway, now that we have 10 experiences as opposed to being able to list your entire CV, I probably just go there first and just see what you have to say. I'm not honestly looking for anything in particular. I do like seeing things like customer service jobs, work experience of some sort, dedication to something. I'm going with something. It's something that you've done for years, not something you did for 6 months. I also really like the hobby section. The hobby section is probably one of my favorite sections of the application, because that tells me more about you. So list things that you would actually have as a hobby. Skydiving once is not a hobby. That was an excursion. Go with that is something else there. I'm just saying, the thing you did one time, I don't know about that. But also I caution you with, if you write it there, I can now ask you about it. So if you talk about your dog Sparky, don't be surprised when I ask about what kind of dog Sparky is. Don't look at me like I have 6 heads. You wrote it in there, so now I can ask you about it. So just be careful about what you write in terms of what you want to talk about. But I think everything that you write in the experiences section now is really important, because you only get 10. So write about things that interest you, that you think other people would be interested in talking to you about, not necessarily the thing that you think is the most impressive, because to be honest, it might not be as impressive as you think.
I hope y'all are getting these pearls. Keep putting the questions in the box. We will keep answering them. The next one is for you, Cortland. programs merge, hospitals merge, things happens, people got to bring their dollars together to stay open. Is there anything that residents should be cautious about, should be looking out for? Should they be going to HR first before the program director? What are things that students should be looking for in those programs that may be merging sometime soon?
It's a tricky question, and I don't know if I'm necessarily the best person to answer it. So if somebody else feels more qualified, just because I don't have any personal experience. But
the old head has raised his hand, and so thus we will call on our old head to answer the question.
Hey, thank you for acknowledging my status amongst us as the old head. So this is actually something that I'm actually very familiar with because we had a hospital system, two hospital systems that had some pretty impressive tragedies to happen. One is hospital had a catastrophic fire that burned the electrical room in the hospital. Has been closed for 2 years. And those residents had to be absorbed by the hospitals in the area. And the one good thing about residency money is that is hard money. This isn't soft money that's floating around. This isn't grant money. This is money that is coming from CMS. And so that money was transferred to other hospitals, and those residents also transferred to those other hospitals. So the residents had their experience. It just happened to be at a different institution. Now, what does that mean for you if you're in a categorical 3-year residency program versus a preliminary or transitional program? Well, it doesn't necessarily mean that those dollars are going to necessarily stay at the closest hospital to you. And so you need to be aware that these transactions can happen even in some cases across state lines. Now, this isn't going to be the ideal situation. I mean, the most likely situation, but these are situations that can happen. And so what typically happens if a residency, first off, I think you all should do your homework, because if you know that a hospital system is struggling, or you know that a residency program has been on probation or something along those lines, you need to be thoughtful as to how high you're going to rank this program if you're going to interview or even apply to them in the first place. Now, let's say this place is in the perfect location for you from a strategic standpoint because your couple's matching, or you have family in the area and it's really the only residency program, then we understand. But I think you need to also make sure that you understand that you are taking on an inherent level of risk by applying to a program that may have either financial issues because the hospital is unstable, or there's a possibility that the residency is going to close because of academic struggles or probation from the ACGME. So if you are in a situation like that, then ACGME does everything they can to protect the trainees, plus that CMS money will go to a different institution. Therefore, you will go to a different institution, but that can potentially uproot your life. So just be aware, be thoughtful, and decide whether or not it is worth the risk of you, one, ranking to match that program, 2, even interviewing in that program, or 3, if you want to even apply to those programs.
I will also say a good quick aside as a moderator. My program was, I guess, like a freestanding program. My first and second year, third year merged with Central Michigan University. So we got mostly all benefits from our end, right? They started in med school, therefore they needed places for students to rotate. So they used our hospital. So I got new fancy coats, new logos, the sim lab got upgraded. I didn't see really any detraction from that merger. Maybe some people's paychecks and 401ks may have changed up, but as a resident, I just saw all the good stuff. So sometimes merging can be good. The second half of this question, I will kick over to Dr. Chukwuanu. I know you just answered this or answered another question, but as someone who does EM and ICU, I thought maybe you want to dip your toe in here. Do you feel there's any difference when applying to fellowships from someone who's come from a large academic program versus a community program?
Yeah, I think it's always easier if you're coming from a large academic program that has specialty area that you're looking for, or that has previous grads that have applied to fellowship. I know that in my particular case, I did my residency at St. Louis University, and we did not have anybody that had been to fellowship when I was applying, certainly not in critical care fellowship. But that's where networking and reaching out to people like you see here, your colleagues, being involved in things like EMRA, AAM, RSA, going to these conferences and making connections really, really helped, because for me, I didn't have any problems matching or having programs interested in taking me as a trainee. It was more about me just getting my name out there and making connections and getting educated. And emergency medicine does a very good job of that if you're trying to do a subspecialty. So I wouldn't worry about that. I would worry most about being the best emergency physician you can be, and that's getting the best training that you can get that will fit your learning style and make you the best doctor that you can be in emergency medicine to do your subspecialty first, then after that.
Excellent. Anyone else want to weigh in on the getting into the fellowship bucket or question?
I think it makes a huge difference. And that's not to say that coming from any program, you can't get into a fellowship if you want to, and if you work hard, you're going to. It's just so much easier if you're at an academic institution. Number one, the research dollars are there, the grant dollars are there for community projects. Your attendings are doing projects and they're like, hey, help me with this cool new community outreach that I'm doing, or this new implementation of a different workflow in the ED that I'm doing, then let's write it up. So then you're on their paper. So it's just a little bit easier because you have those resources. It is a little bit, another thing that comes in, and this is kind of what we were just talking about, is a lot of it is, sorry, that's my cat, he says hi. A lot of this is also, you know, unfortunately, who do you know who's going to vouch for your training at that program? And so if you are at a community program and you are 100% sure you're set on fellowship, number one, I don't know why you're that set in the first place, because so many things can change. Life can change, fellowships can change, who knows? So I would say keep an open mind. But if you are at a community program, try and go to one where there have been a lot of graduates. So maybe it's an older program, so graduates are spread out over the country or whatnot, but kind of just factor that in as well.
Dr. Landry, I see you're unmuted. Are you unmuted, or you want to weigh in on the fellowship debate?
No, I do. I actually want to weigh in on this discussion, because I think the one caveat I would add to all of this when it comes to applying to fellowship is you need to make sure you love your home residency program first. And you will have either 3 or 4 years in a residency program. And if you chose a program solely because you thought it would put you in a position to go to a fellowship, but you were miserable for 3 to 4 years, then you made the wrong selection. You need to make sure that you are going to love the place that you are training for the first 3 or 4 years. And if a fellowship happens to be in the cards for you, that's great. But there's no point in sacrificing 3 or 4 quality years of really tough, important learning that you're going to be doing with the hopes that you're going to match into a great fellowship spot.
All right. I'm going to start with Dr. Bradby on this next question, but I do want everyone to weigh in on this question, because we get this question every year. I get this question multiple times a year, and it goes back to working with MD and DO students. For DO students, from your program's perspective, starting again with Dr. Bradby, is it better to take COMLEX or USMLE or both, or does your program not care?
I mean, I don't particularly care. I think it's stupid for you to spend so much money to take 2 tests. So particularly now that both level 1 and step 1 are pass fail, like if you passed one, I would presume you would pass the other. I'm not real bent about it. That being said, that's me, and I can tell you there's plenty of programs that definitely disagree with what I just said. So I think if you're the earlier question about like should osteopathic students apply to allopathic programs that haven't taken DOs before, you should definitely have a step 2 if that's your strategy, because they are trying to compare apples to apples, and the COMLEX and the USMLE are definitely apples and oranges. And so if there's a program that has not really looked at that before, like looking at a 500 level 1, like level 2 score versus like a 230 step 2 score, they know what the step 2 score is. They don't know what a 500 COMLEX is. So, and nobody is going to sit here and do all the math out. I'm going to be honest. There's like an algorithm or something. Yo, that sucker is complicated, and ain't nobody got time for that when they have 1,000 applications, and we're just not doing it. So if you are applying to places that have been DO friendly in the past, they should say on their website what they want in terms of testing. It should have the requirements. Yes, we require the USMLE. we don't care either way, whatever, but it should say it on there. And I think EMRA Match also maybe asked that too on their website. So I would say do your research on that. But I personally do not understand why I would need to see 2 passes for level 1 and step 1. If you're gonna take the USMLE, I would prefer to see step 2 only if you're gonna do it. And if you don't do it, that's fine too. I ride with whatever you got.
I want everyone to weigh in because I know all the DO students are going to be feeling the palpitations. You can keep it short or long. Cortland, what do you think about Comlex versus USMLE?
What she said.
I love it. Dr. Chukwuanu, what do you think about Comlex versus USMLE?
I think what Dr. Bradby said is correct. There's going to be some programs who want to see both, especially for the step 2 and level 2. We're going to want to see both. I agree that taking step 1 and level 1 doesn't really make much sense. I am wholeheartedly against making students take 2 sets of tests, and it infuriates me. And I'm always on my faculty about this should not be a thing. And we should just learn to adjust that there are DO students and MD students. So I didn't look at step 1 scores when they were scores before. If I'm going to look at a score, it's going to be a step 2 or the level 2 score. And I would go off of that. But there are programs you're going to have to take both, and you're just going to have to do the research to find those out. Use your Googles.
I love it. Dr. Landry?
Yeah, I'm going to go ahead and say that there's bias at my institution, and they won't understand math when it comes to converting to a complex to a USMLE. So if you're going to be applying to an institution like mine, just have USMLE step 2 and make it simple for us. Otherwise, my program director and the leadership is going to be scratching their heads. So just make it simple for us.
I thank you all panelists for your honesty and for these insider tips for our students. And I can tell they appreciate your tips because as you were saying them, the number of questions are now increasing. So they're feeling the love here. So I'm gonna start flying through some of these. All right, I'm gonna start with you actually, Dr. Landry, because this is an old headish question, and then I'm gonna co-answer this one. What opportunities are there for career transitions within EM, and what advice do you have for physicians looking to diversify their roles within the specialty? And if there's one thing Dr. Landry loves, it's getting paid to not have to be in the department sometimes.
Yeah, but I also love emergency medicine. And so I want to start there. I think the reality is you can't go into emergency medicine thinking that this is the short-term game. You have to plan for a career in emergency medicine. I can guarantee that pediatricians, internists, neurologists, psychiatrists are not thinking, what's my 5-year, 10-year exit strategy? And I think people have historically done that with emergency medicine with an idea that they would transition up in the academic or professional ladder within hospital systems or a transition out into other spaces in medicine. But again, I caution everyone, just like I say, you don't choose a residency program because you're thinking about a fellowship. You don't go into emergency medicine thinking in 10 years, I'm not going to be practicing emergency medicine, because that is the wrong approach to choosing a specialty. You need to make sure that you love emergency medicine and are willing to do this for the long haul. Now, what is the long haul? Well, yes, emergency medicine, we can, the elephant in the room is that there's a high burnout rate amongst emergency medicine physicians, and there's a high turnover in emergency medicine. I think a lot of that is actually, I think that turnover rate is partially related to the fact that emergency medicine physicians are so transportable, and we can go other places. We're not moving a practice when we move. We're not telling our patients goodbye. We're picking up our stethoscope, moving to the next hospital system and learning how to order a CT scan. I mean, that's what we're doing. We're going to situation. So that is very different than what other people have to do when it comes to making a transition within the specialty. Now, are there opportunities beyond emergency medicine? Absolutely. Because I guess in the grand scheme of things, when you do shift work and you have, especially when you get to the stage of my career where you can control your schedule and you can move your shifts around, you can say, I don't work Tuesdays and Thursdays because those are my administrative days, then you can build other things into your career. And plus emergency medicine, we see it all. And so we can offer insight into other aspects of medicine, more so than a lot of our other colleagues. And so I think there are a lot of growth opportunities with this. But again, you need to love emergency medicine if you're going to choose emergency medicine as your residency before you decide what is my career going to look like afterwards. Now, I can tell you, the great thing is I'm on the back end of this, and I've already done my time in the emergency department. I've paid my dues. I've what is the Malcolm Gladwell 10,000 hours? I'm probably somewhere near that 1,000 hours, if not more. So I'm in emergency medicine, and the opportunities are endless. And I get asked to consult in different spaces. I get asked to advise in different spaces. I'm in academic medicine, so that's to be more comfortable. But I get especially doing DEI work. Before what was happening right now with the anti-DEI movement, I was getting emails and calls about job opportunities relatively frequently within, I would say, once every 2 weeks, if not once a month. Now, do I still get those opportunities? Absolutely. But I have to be very thoughtful about what's going to be the best opportunity for me. So emergency medicine, great specialty and opportunities to move in different spaces, but make sure you love emergency medicine first.
Agreed. I'm team admin. I will just say, if you like being chief resident, you may like being a medical director. And that's how I'll leave it like that. Starting with you, Cortland, on this question, and then I'll go over to Dr. Bradby. How does your institution weigh signals? There's been a lot of studies that shown that there's been an increased correlation between those who signal and those who get interviews at institutions. So how does your program use signals?
I don't necessarily think that we care as much as other places might. Because I think it's basically, how can somebody know about a program until they're really there and interacting with that program, walking through that ED, seeing how the patients are treated, seeing how diverse the patients are, seeing how the residents, fellows are feeling, how's everybody interacting. So yeah, that's great if you signal us that you're really interested, but we don't want to pass on somebody that might bring more to the residency, and we might be able to, contribute more to their training just because you looked at the website and thought that it was a good fit.
Dr. Bradby, how is your institution using signaling?
I think it's helpful for the folks that I can't figure out why you applied here. So, like, you have no ties to the area, you have no ties to the Southeast, you're from Walla Walla, Washington, you grew up in Washington, you were born in Portland. Like, I'm like, this cat is not coming to Eastern North Carolina. But if you're gonna spend one of your 5 signals, like, on me, then I presume you really are interested in coming here. And if you were a solid applicant anyway, I would be inclined to interview you. And I'm talking about like an applicant that's not a bad applicant. They're a perfectly great applicant, but I couldn't figure out why they were coming here, and so I might not interview them because they were perfectly great and I can't figure out why they're coming here. And so I feel like the signal is helpful then. If you are not a great applicant, if you have a lot of red flags and whatnot, simply signaling us is not going to be enough for me to interview you. So I will tell you my personal opinion is, as a solid applicant, send those signals to who you believe that's where you want to be. Like, I don't think you should try to parse out, well, I think these people will interview me and these people won't interview me or whatever. You'll never figure that out, I promise. So you might as well just like send them to the places that you really want to be. The other thing I will add to that is the little bit of strategy that you might want is, I think 23% of the signals last year went to the top 20 EM programs. I don't know what the top 20 are or what that means or what the criteria was, but I know that 23% of the signals went to them. And so knowing that, my guess is a lot of those places maybe only interviewed people who signaled them because they could. I don't have that benefit, nor would I probably do that, to be truly honest. But I do think it's important to keep that in mind, as well as, like, if it's a super popular program, you're a DO applicant, they've never taken a DO before, I don't know if it's worth spending that signal or not. That would have to be an internal decision for you. But for the most part, I would say, like, send them where you think you want to go and see what happens.
Portland, you want to re-up your answer?
I do, because I actually just texted some other residency leadership just to get their perspective. And so I would say we're a pretty popular program. And so other residency leadership was basically saying that how we view signals is when it comes to like the last spaces that we have for interviews, basically. And then we'll kind of look at that. So maybe the last like 1/4 of our spaces for interviews, but beyond that, we kind of just really go with who seems like they'd be best with the program. And then we also put a ton of weight on, if you rotate with us, how do you do? So every single year, our intern class is at least 50% of individuals that did fourth year rotations with us. And that's at least 50%. In past years, it's been like 80%. And every single program is different on how they weigh if you do a sub-I at their institution or not, and if they care or whatnot. But I would say Carolinas in particular, like if you come here and show us that you would do really well here and we'd be able to help you do really well, that honestly matters so much more than a signal to us.
That is a huge pearl right there. So you guys, signals do matter. I'm trying to pull up my presentation from earlier in the week. I do know that I can say for this year, EM changed the number of signals. So if anyone remembers the exact number they changed it to, I think they went up or did they go down?
It's 5.
5.
5 signals.
It was 7. It went down.
It was
It went
7,
down to 5.
That's right. I knew it
And
was down.
and specifically, do not signal your core home rotation or the rotation that you went away on. Those are basically wasted signals. They already know that you're interested in those. You presumably are interested in those programs if you went away and did a rotation. I would say for the signaling portion, just to counter what Dr. Bradby said just a little bit in terms of being strategic, you can know how you are as an applicant, your level of competitiveness as an applicant. And if you know that you are on the lower end of the competitive scale, that doesn't mean can't match emergency medicine. It may mean that you are not going to get to one of those, top programs or more popular programs such as Carolinas, where Dr. Brown is at. But it doesn't mean that you can't get a good training program somewhere else. So you have to kind of work with your advisor and figure out, where your level of competitiveness is, and then where you should be applying.
Well, I'm gonna keep you right on there. Don't mute that microphone. You got the next question there. Since you want them to apply and talk to their mentor, what are the main qualities that you think the mentor should be telling them to highlight? Is there anything specific that sets accepted applicants apart? I know we heard of people who rotate at shops just a second ago. Anything else you'd recommend? And then Dr. Bradby next.
Yeah, I think rotating at a specific place or applying to rotate there, even if you didn't get the rotation there, you applied to rotate there and maybe they took other people, that's definitely going to show your interest at that particular place. When I'm looking at an application, I am looking at experiences mostly importantly for me, is what you did in medical school, how dedicated you were, because it shows me a little bit of your work ethic. And so me, I'm number 1, 2, and 3 qualities are work ethic. Like I want to know that you're able to work and adapt. And then after that, it's like teamwork and, if I can trust your word, and then how you are, as a person and as well. Those are all kind of things that are combined. But I think the main qualities of me is your work ethic, and then your adaptability and your ability to be in a team, both eventually as a leader, but can you follow first? Right? Can you be a follower and then improve and to become a leader?
And Dr. Bradby, anything you'd like to highlight outside of watching multiple seasons of The Mandalorian?
Yes. I agree with everything Kenneth said. That being said, I also am looking for adulting. I'm looking for adulting, and adulting. I want somebody who I am not going to chase to fill out the paperwork to keep their job. I want somebody who is going to do the cybersecurity module without me having to make phone calls to be like, please do this crap. Because look, I don't really care about it, but the hospital does, and they employ you and they will fire you if you don't do it, which means then I get in trouble when you don't do the thing. And I don't like that. I'm also looking for professionalism, which goes with adulting. But like, please don't have like a bunch of professionalism marks on your application. Like, be nice to everybody. Be nice to the program coordinator. Do not be snippy in your email when you didn't get exactly the interview day that you wanted or whatever and whatnot. Be nice to the clerkship coordinators, because don't rest assured they came to tell me that you were annoying when trying to make your schedule for the rotation, and they don't like that. And if they don't like that, they don't like you, and then I can't hire you because they're the people who do most of the work around here and they can't cause me problems. So professionalism, and I need you to like try to major in adulting before we get out of medical school.
Love it. Cortland, I see your hands up.
I love those answers as well. And then I would just add to them any sort of passion. Doesn't matter what it is, but we want to see that you are passionate about something and that you've committed and devoted to it. And so I think that's where actually we might be looking less for a applicant that has, I mean, earlier we talked about somebody that has, you know, something checked off in every box. I think that's actually less important for our program. We just want to see, like, have you identified something that you're passionate about in emergency medicine? And what have you done to contribute to that? And we also want to see growth. So we want to see that you're somebody that can come to a program, can make it better, and we can make you better. Because otherwise, what's the point of having a resident and what's the point of going to residency? And then I had one more and now I forgot it because I got so excited about passion and growth.
We can come back. Don't worry. We got
Yeah.
more questions. We can come back.
It was adulting. I promise. It was adulting.
I'm not adult enough to remember that.
I will say, if you cause no waves, you will go very far. It's one place where it's the opposite. Dr. Landry, this one's coming to you. We're starting old head first, and then I'm gonna go probably the next question after this, because I think your answer will be your spot on. Do you
Wait,
foresee?
I remember.
Go ahead.
We have a responsibility to our patients. So we want to see and know that you can come in and you can treat our patients with respect. So we are, you know, not technically a county or community hospital, but Charlotte doesn't have a county hospital. And so that's the patient population that we serve. So we want to know that we would be comfortable with you talking with our patients about, you know, their food insecurity or anything that they're struggling with. And if you're not comfortable, that you would be willing to admit that and want to learn. So I think that's something.
Let me tell you right now, as a medical director for a rural hospital, those Press Ganey comments hit extra hard because the community about this big. So it doesn't take that much. Dr. Landry, do you foresee us going back to in-person, the good old days for residency interviews where you had to fly across the country, or are we stuck with Dalamis and the virtual interviews for the time being?
You know, I think that there's been discussions at all levels, especially in the program director space, about this. And to be honest with you, I think that emergency medicine is one of the many specialties that's going to stick to the virtual format for the foreseeable future. I think one of the things that it is a leveling. It does level the playing field, and we can interview more people, and we can see more applicants. There are the specialties that are pushing for in-person, and I think it is going to be really a specialty by specialty decision that is going to be made as opposed to institution by institution. So I think if emergency medicine leaderships across the country say that we want to stay virtual, then you're going to see us stay virtual. But we're I think 2024 is a virtual year, and we're planning for it and adapting into new systems and trying to figure out which is the best platform to engage with our trainees. And I wouldn't see that changing. But if you do see it changing, it's not going to happen this application season.
We are going to get to both anonymous questions, but in true EM fashion, I'm going to say burnout until the end. But I'm not going to forget you, burnout. I guarantee we will answer your question. This is one I think everyone enjoys. So I'm going to go to everyone. What are some of the biggest red flags you've ever come across during an application during interview season? Any flag at all would stand out. I would say one of the flags, I don't work at a residency program, but way back when I was chief having to interview people, I do remember that there was someone that forgot to like switch the specialties in their personal statement. That was funny.
Yeah, I'll go ahead and run with this one. So I think number one, to Dr. Bradby's point earlier, if it's in your application, it's game free. You know, we're going to talk about it. We're going to ask about it. And someone had the audacity to put into their application that they enjoyed beatboxing. And I said, beatboxing? Oh, perform. And there was a look that came across as if I had asked them to do the unimaginable. And I said, well, look right here on your application, my friend. You said you beatbox. I mean, I have high expectations. And they completely froze. And I'm joking when I say this. Everything on your application matters. If you're going to tell me you beatbox, you better be like, I mean, honestly, this was like that person who was in the Olympics trying to say that they were breakdancing and was struggling and doing a twirl on the floor like my kid when they're having a tantrum. So that's number one. And then this isn't necessarily related to the application, but this is something second to the application is when you send that I love you letter to the program director, send it to one program. And I had a person send that I'm going to rank you number one, and they put a different program in that program name. So they sent to my program director and they said, BI, I love you. You're a wonderful program. I hope to match there. You are my number one. But then in the middle of the email, it said a different residency program. And the program director is like, you see this? They don't want to come here. They're sending this email out to multiple programs. So when you send that, hey, you're my number one letter, you send it to one program and one program only. Don't send it to everybody because that person was not on our rank list because of that error.
This is EM, y'all. Fake it till you make it. They tell you to beatbox. You drop that just a friend beatbox. You drop that play.
Hey, I was expecting some Dougie Fresh. I was
something. All right, Dr. Chukwuanu, I want a red flag from you for the students.
I think red flag for me would be professionalism, and not really taking your rotation seriously. So if I'm reading your MSP, and I will read your MSP, sometimes even over your personal statement, I'm going to look for language in there. A lot of medical schools try to clean it up. That's fine. They can try to clean it up. But I'm going to look for consistency in how you performed in your rotations, especially in your advanced clinical clerkships later on in your third year and your fourth year rotations that are related to emergency medicine. So I think being professional is a big thing, which goes along with adulting, as Dr. Bradby would say, is making sure that that's consistent throughout medical school and that you're a professional, because you now are getting a medical license, you're now getting a medical degree, you are a doctor, you're at the pinnacle, at the top of our American society, and you should be a professional when you come out.
All right, Dr. Bradby, you're going last because there's a question specifically for you in the chat, and the student, if you need further input from Dr. Bradby, let us know. And so you'll go last, Dr. Bradby, so you can keep typing. Cortland, I'll let you go. Big red flag.
I would say if you say you care about something a lot and build your application around it, but then literally only spent a week doing it. Like that doesn't add up. I don't get it. So
I'm warning y'all right now, don't put I'm part of SNMA in my application and interview with Cortland and not know nothing about SNMA.
Oh, I've caused people out. I've caused people out on that. Yeah, in the past.
That's a huge one. All right, Dr. Bradby, red flag.
One, lying. You would be surprised at the number of people that we know. Like someone did research in STEM at MIT, and the PI on that study was my high school classmate. And you would have no reason to know that. So like, don't lie and say you did some stuff you didn't do. Don't show up at a second look and then find out that the alcohol isn't covered and then walk out, because the owner of the business probably knows the program and is going to rat you out. That legit happened in the before times, y'all. Like they came to the pre-interview dinner and they were like, oh, alcohol isn't covered, and walked out. They were not ranked. Do not piss off my program coordinator in any way, shape, or form. If you annoy her, you will have now annoyed me. And nothing you say from that point on will matter. Trust and believe. Because guess who actually has access to the rank list besides me? So I'm just saying. And then I would say the fourth thing is language. So two language things, like sound like a real person, first of all, but like watch your language, don't go crazy. And two, if you say that you speak a language, it goes with the beatboxing thing. You don't be surprised if someone tries to conduct your whole interview in that language. Like, be honest. If you are fluent in Spanish, cool. I have a faculty member that will legit conduct your entire interview in Spanish because that's easier for her because that's her first language. So like if you can't come correct, she's going to report that. So be careful in like what you write there.
Start working on the conjugations, y'all. All right, we have 5 minutes. We're gonna try to knock out both questions, but I did promise the burnout person first. So we'll start there, and we'll start with the person who's actually on vacation right now to answer the burnout question to say, has EM improved in combating this? Dr. Landry.
Yeah, I think it has. And I think that emergency medicine goes through these waves. And you have to remember, Burnout comes from many things. Burnout comes from the fact that we see people our age dying from preventable disease or from trauma, penetrating or blunt trauma. We see burnout because we have pandemics and we're on the front lines. We see burnout because we take care of patients who are victims of sexual abuse, child abuse, things along those lines, elder abuse. So burnout can come in many different directions and many different causes. And so what I've seen is across the board, programs are putting in place to make sure that trainees and faculty have access to mental health services, have appropriate time off, that they're doing things to make sure that the scheduling is fair and balanced, not the Fox News fair and balanced, but the fair and balanced so that you're on a appropriate circadian rhythm cycle, or that you are actually having time off to take care of your personal life or to do all of the things that are important to you. But you have to make sure that you are communicating to the people around you and you are taking care of yourself. Residency is hard, and it's not going to get any less hard for the foreseeable future. The structure is the structure. That being said, there are things that are happening more and more to make sure that we have a sustainable career in this specialty. And then there are other things that can happen that are outside of emergency medicine that can contribute to your mental health and wellness, whether it be tragedies in your family, personal struggles, financial struggles, whatever. And I think it is important for you to think about this specialty and understand that you are still going to be a human as you practice medicine. And you have to understand that you have to protect yourself, both what's happening at the workplace and then also what's happening at home. And I will tell you this, one of the things that I have had to really focus on is to take my work life home and bring it to my wife and my 4 beautiful children, because they deserve the best in me and they deserve the best husband and father that I can be. And so I have to do my best to protect them. And part of that means I do the things that I need to do to make sure that I am healthy, both physically and mentally, in the world that I live in.
Thank you, Dr. Landry. We'll get to what will likely be our final question. Before I get there, Cortland, is it okay if I share your great quote there with everyone? Okay, I will. All right, so final question. And I know a lot of students have this question, so thank you, Anonymous. And we'll start with Dr. Bradby here. What about the obvious red flags that you nice panelists have desks that may shield some people from getting to your desk? Step 1 failures, repeating a year off, things like that. Is there anything they can do to get through some of these filters to jump over them? Is it the signaling, the homie reach out? Starting with you, Dr. Bradby.
I think the places that use filters are going to use the filter. I mean, it is the way the filter works is that they never actually see your application. It's been sorted out. But if they know you, they could actually go look for that application. Like if you send in your AAMC number, like ID, you can go search for that application. Like for me personally, like I look at all of those things. I don't set any filters. Partly because I don't like filters and there's more to someone's story than their one screw up in life. Like life happens, and the reason you failed could have been something super legit that I would look at and be like, man, if that happened to me, I would just quit med school. So this person gets kudos for me for surviving. So I don't use any filters. But I will say that like if I know you, like I'm probably gonna come look for your application first. I have 2 reasons for that. 1, I will email you and tell you, hey, I can't find X, Y, and Z. Go fix this thing. Or 2, I might email you and tell you that like, hey, your application's complete. Thanks. I just want you to know that to reassure you because like we have that kind of rapport. The other thing I want to say about red flags is, look, you know what your red flags are. I don't have to tell you what they are. You got to apply with what you got. And the more you explain, the less I have to make up in my head. And so if you just throw it out there and don't explain it at all, we will fill in the gaps and it will be to your detriment. So make sure you explain whatever your red flag is to the best of your ability and explain it in a way that it doesn't create more questions if you can, and in a way that does not cause tragedy in your life. And what I mean by that is if someone has died and you can't really talk about that, it might be important to talk about how important this person was to you and whatnot, so that we don't ask you about it on your interview day, because crying on your interview is like uncomfortable for you and uncomfortable for me because I can't even offer you a tissue through the screen. So like it's just just be careful in what you write there, but you want to make sure that you address it so that we don't try to address it for you.
And Dr. Anani, that was
Yes.
such a great comment by Dr. Bradby. I just want to add that if you have a red flag and you don't know how to address it, have one of your letter writers to help you address that in their letter of recommendation for you, because you're going to have a SLOE, you're going to have your MSPE, but a letter writer who knows you and has mentored you can also help to address those questions so that program directors, when they're evaluating your application, can see that that red flag was the result of a tragic incident that happened or something that was overcomable for you, and you are now a better applicant because of that. So use your letter writer strategically. And I think that's something that we didn't touch on them in this discussion. I believe you touched on in other parts of this, these panels, but letter writers are so key in helping to address many of these issues.
Dr. Chukwuanu, I see you're unmuted.
Yeah, I think that I agree with Dr. Landry. Like that's letter writers, especially a traditional letter, a recommendation that can write that in a paragraph, like in a real letter format, to address that for you or to help you address that. The other place would be the impactful experiences, and then the other place would be your personal statement, depending on how you want to use those. Would be places to kind of address any red flags or specific challenges that maybe hindered your medical school performance, but aren't the total you. Like don't really say the total you of what you can do clinically.
Portland, you have the final say on
Well, that's stressful.
it.
I would say, so for personal experience, I barely passed step 1 and step 2, literally passed them by like 1 or 2 points each. I will always do terribly on standardized tests, did the same for the boards, literally everything. And so I had those big academic red flags where, I almost failed. I had to delay things. So my timeline was messed up. I also came into EM super late and dual applied into child psychiatry as well. So I agree with everything everybody said. I would only add address it and let it drop. Because I know I personally was always wondering on interviews, like, should I bring this up? Should I talk about it during the interview? And my personal answer is no. That person has already probably read your application. And if they have read it and they want to ask about it and they want to talk about it, they will. Like, don't continue to drag on it. But I do agree that you should address it kind of head on, however you want to do it, but then let it be. And whatever's going to be with it is going to be with it. You did your job disclosing it and explaining. That's all you can do.
Yeah, there's no need to put it in more than one place. Like there's multiple different places to address these red flags, but don't have it in all throughout. Don't make it a theme of your application, the red flags.
I will use that as a jump off point to wrap up in the last minutes here. Failed step 1, passed step 2 by I think like 5 points or something, and even failed a couple of my board takes for EM. It now says FACEP at the end, so I'm done with that. But it happens. And I will say the biggest thing to combat red flags is you, right? Get in front of people, and that's hard to do during ERAS. So go before. Away rotations are huge. Go to some place that's not your home shop and stand out. So when you got a letter writer from somewhere else, maybe like from Harvard, and you're applying somewhere else, and like, whoa, the guys at Harvard like him. We know Harvard might use filters, so they're not going to take him, but they still like him as a person. That will stand out. Courtland?
Sorry, I don't actually like having the last say, but wanted to add something to that. 100% agree. You would also be incredibly shocked at the number of times I give out my email or something if I'm at a conference. So if I'm at AMEC or the LMSA conference, I will give out my email probably to about 50 different people. You know how many people actually reach out to me? 2. Yeah, literally 1 or 2. There are still people that they're now senior attending, some of them have retired, that I am still in contact with because on the back of their business card then I wrote, we talked about pierogies. And then I emailed them after the conference and was like, hey, we talked about pierogies. Like, where do you like to get them? Oh, by the way, I see Charlotte has a great pierogi place. Tell me more about the city. So literally, like, I can guarantee there's interviews that I only got because I actually reached out to somebody that I met at a conference and then they kind of nudged the program director on my behalf. I guarantee that happened. And never feel like you're bothering somebody. If you were bothering them, they wouldn't have given you their business card and their contact. And if you're bothering them, they're just not going to respond. It's not going to make them view you negatively.
Big facts. On that note, because I have to respect the panelists' time, they've given an hour of you, as you can all see, of their very important time. Thank you all to all the panelists. Thank you to all the attendees who stayed with us. Thank you to SNMA. Thank you to LMSA. For those who are watching this later, thank you for clicking on the YouTube link. For all the attendees here, you can follow the Tour for Diversity on all of our socials, Instagram, Twitter, LinkedIn. For all of the panelists, I can try to help you connect with them as needed. But like Cortland said, if they don't respond, don't take it personally. They're shifting through literally thousands of applications in the next couple of months. But we got your back. I mean, we're literally all in one big group chat. So we got your back. Good luck to you all. We wish you a powerful and successful season, and we'll see you on the other side in one of our shops. Have a good evening.